Last week on the podcast, I showed you part one of a lecture that I gave at the Eisenhower residency. Huge shout out to the Eisenhower Emergency Medicine residency and Matt Whited, who is a good friend of mine who works there, also ultrasound guy. Now we're going to continue on this week with part two. In this one, we're going to talk about the brachial plexus, the erector spinae block. We are also going to talk about the fascial Yaka compartment block and some other options for a hip block that you might need to do. And we're going to go through some cases at the end. Check it out. One of my favorite things to do is brachial plexus blocks because they work so well. That this was a very gnarly recurrent abscess. It was a IV drug user, but they also have pain, right? They also this looks painful for anybody. And there have been local infiltration, I feel never works for armpit abscesses, right? And you can do these blocks and actually block that. I'll do a quick aside on axillary abscesses. You can actually do serratus blocks, which I know that you guys do here. For an axillary abscess, that works. And you can also do a brachial plexus block. Now, I actually mostly do the serratus blocks because I don't want to block motor to drain an abscess. And if you are doing the brachial plexus block, you're going to block motor. So probably serratus block is a little bit better. So here are your locations that you're going to go for with those four types of blocks. We have our interscalene, our supraclavicular, our infraclavicular, which includes the Raptor. Has anybody done the Raptor?
I've seen the other ones.
It is not useful most of the time. I don't know, it's I'll show you how to do it. I don't get why we need to do that. The one thing is that with the interscalene, the phrenic nerve comes off right at the roots, which is where you're doing the interscalene. So one of the contraindications is if someone needs oxygen or if say they have a pneumothorax on the contralateral side, I would assume that every time you do an interscalene brachial plexus block that you're anesthetizing the phrenic nerve, meaning their breathing capacity goes down. It's not symptomatic on almost everybody, but if they're brittle COPD, they're on oxygen, they might notice it, so I would avoid that. The supraclavicular, if you do that, you have a way decreased risk of phrenic nerve paresis, but there's still a risk. Whereas with the infraclavicular and the axillary, there's no risk because it's far enough away. So that would be the one time that I would maybe consider doing the Raptor block, which I've done a few times and it's okay. So the interscalene here, think about it as proximal shoulder. It doesn't get C8, so it doesn't do the entire medial aspect of the arm. So it's not really that great for fractures past the proximal shoulder because it doesn't really do C8. It is I think that one of the easiest blocks of all time to do. Be very careful with what I mentioned with that phrenic nerve. We have that supraclavicular, which is an arm spinal. It gets everything. And so basically from the shoulder down, you are going to be, your patient's going to be completely numb, which is great, which is what we want. This is an intermediate level block. If you haven't done a lot of nerve blocks, I wouldn't start with this block because there are a lot of important things in that area that you can accidentally poke that can cause a lot of problems. The infraclavicular is kind of I mentioned why, you don't need to do it most of the time, and it's much more complicated and a little scarier. You have a variation. The Raptor stands for it's one of those those acronyms or whatever that was a reach. It's the retroclavicular approach to the posterior something. I don't know, it's this interesting mnemonic. It's a cool name. It's a Raptor block. But I don't know, I don't always do it. I don't like it. And then the axillary block, it's to me, it's worse than the infraclavicular blocks. And you have to block the musculocutaneous nerve separately because it's already branched off at that point. So if you do an axillary block, you actually have to do two nerve blocks because you have to do the musculocutaneous nerve, which is going to be a bit anterior and lateral. Let's talk about this one, which is a great gateway block, I think. You place your transducer transverse over the neck, and you go through the trap to get there. Now here is the brachial plexus. We got the middle scalene and anterior scalene. It's in between the two. And then we have our needle in long axis. What we want to do is we want to place that anesthetic in the interscalene groove, and we want to see the brachial plexus basically get pushed away from the middle scalene. That's actually how we know that we have a good block. So right here, you see how the brachial plexus is being pushed away from the needle? That's actually what you want to see. You want that anesthetic in that interscalene groove. Any questions on that one? Great. We'll move on to the supraclavicular, which we started off with the transducer here for the interscalene. We're going to go down to the supraclavicular, and it's the same basically approach right through those traps. Here is the approach to it. What I generally do if I'm having trouble identifying it is I'll go up higher and I'll firstly identify the interscalene brachial plexus, little stoplights up there, and then I'll actually track it down to the kind of junction where the subclavian artery starts and follow that structure down. And if you follow that brachial plexus, you can see that it remains a persistent relatively hyperechoic structure. Interestingly enough, if you're above the clavicle, the nerves are hypoechoic, and if you're deep to the clavicle, they're hyperechoic. And some with myelin or something or other. I don't know. If you're not sure if something's a blood vessel or a nerve, by the way, just put color Doppler on it. If it's got color Doppler flow, it's a vessel. If it doesn't, it's your nerve. You can see here that there's a lot of scary structures really close, right? You're coming posteriorly, you're coming from this way, but you have your carotid, aka your brachiocephalic, you have your lung right there. Like it's all very close proximity. So this is why I say it's not a good block to start out on. Like it's a block after you have like 20 under your belt, from my opinion. Like you have to have a few under your belt before you try this, because you don't want to do this. You don't want your needle to go all the way through and pop a lung. You don't want it to accidentally go into the carotid artery, because then we cause issues. Now, if and when you do this, there is a way to create a safety, like a backstop. And what you do is you just rotate your transducer until you are long axis to the first rib. And see, if you do it this way, in this orientation with that transducer, your transducer is staying fixed at this point. You are watching to make sure that your needle is perfectly aligned with that transducer. You come in posteriorly, and if you happen to go a little bit deep, you're going to hit a rib. You're going to have that tactile feedback of poking something, right? So you guys see it's flipped. It's the other side on this patient. There's that brachial plexus. There's the needle. And we can see here, I sped it up because it takes a little while to get all the injection in. What I do with this block, because I'm impatient and it's easier to do, is I will back up and then redirect to go up and around that brachial plexus, and I get a much more dense of a block. Now, if you just inject on one side of your nerve, it's okay. They're going to get anesthetized, right? I think about it like a croissant, just on one side. It'll eventually diffuse all the way through. They've done studies specifically on the sciatic nerve, which is a very interesting nerve, by the way. It's my favorite nerve. It will eventually make it, right? If you do like a donut block, which is like above and below, it will also numb it, but way faster, because now it's diffusing to the center on both sides. So if you want it to be done quickly, do it on both sides, but you don't need to. You can just do it on one side of it and actually be fine with it. Now, we know a lot about this one, right? The Erector Spinae block here. I know that we just became the champions of research, right? Of the ESP. But it's the same thing. Like the serratus anterior and this block are like this. I think they're the same block. It's just doing one back here and one a little bit forward. This one is one of my most useful blocks for back pain, because we have a lot. Thank you. We have a lot of chronic back pain in our ER, and I've actually used it for all these things. It works for the serratus block as well. Work for visceral pain. They work for organ pain. So if you have somebody with intractable kidney stone pain, pancreatitis pain, these plane blocks can actually help with it. Shingles pain. I've had a patient that had horrible arm shingles and was a 70-year-old man and had it for 2 weeks and had been on all the medications and was literally like crying. I felt so bad. And I did a block. It was at chest wall, and I did a Erector Spinae block on him, and he had zero pain when I discharged him. He went from intractable pain on gabapentin, on Norcos, on everything else, to zero pain with this block. And then we have, of course, a pinched, cauda equina, we have pinched nerves, and this block actually works very well for that as well. Now, with regards to the anatomy, we are going to identify, the laminars can be a little tricky, but we identify the spinous process, which is as you're moving side to side, because our patients, especially if they're a little bit on the fluffy side, it might be kind of hard to see through that subcutaneous tissue, because remember, the ultrasound beam is calibrated to go a certain speed in tissue, and that's what it assumes. It goes a little bit slower in adipose tissue. So if you're shooting through adipose tissue, your probe's not going to see as well, so that's why your image can be a little fuzzier. You identify the spinous process, and then you come at it laterally, and you're going to get another kind of bony groove, which is going to be the lamina. And then you keep moving out until you get to the transverse process. See how there was a difference there? There's like a really shallow one, a really deep one, and then kind of an intermediate one. That is your transverse process, and that's what you're aiming for with the Erector Spinae block. Now, you want to make sure that you see a flat surface, not a curved surface. If you see a curved surface and lung sliding deep to it, you're too lateral. And we would not recommend going more laterally to where you might accidentally poke the lung, and it is less successful if you do it out laterally. So you want to do it right on the transverse process. Make sense? All right, and here's what it looks like. This is like the same clip, but you can see the person I'm scanning. So we start off, there we're seeing the lamina, and then we're going to move a little bit more laterally, and we're going to see a little bit of a jump. There's going to be another bone a little more superficial. That's the transverse process. It's kind of flat. This is where we want to do our injection. Right on top of that, we're separating out the Erector Spinae. We're pushing it away from that transverse process. That's our goal. When we're in the thoracic region, we can do it in plane, and it's probably better. I usually do cephalad to caudal, but, which I'll talk about it, we do a lumbar ESP, the way out of plane, and it works so good for intractable back pain. But we do that out of plane because it's difficult. The depth is too great. We'd have to traverse, like you think like the hypotenuse. You'd have to transverse like 15 centimeters on some of these patients, right? Because the angle is so not great. So this is the approach. Here's an example of doing this block. This is not the best location because what you want to do is you want to aim so that your needle tip is backstopped against one of the transverse processes. So this is a little off, but we had really good spread of the Erector Spinae off of the transverse process and the ligament over here. That's why we have it in here. But try to aim for that transverse process. We can do the same thing in the lumbar spine, right here. And it's the same structures. It's a little bit different shape, but it's the same structures, and our target is going to be there. And this is the one that I use the way out of plane technique. I don't have great needle visualization with this because I don't have room, but I'm using hydrodissection. And the hydrodissection, remember, it spreads cranial caudal and then transverse to medial. So even if your transducer's beam, even if it isn't right where the needle tip is, if you're doing hydrodissection, the hydrodissection from your needle that is not right underneath that transducer, that spread will spread to where you can see it. So you can kind of identify where your needle tip is based off of that hydrodissection. And here is an example of that. So see, we don't have great visualization, but can you guys see that separation right there, that kind of unzipping of the Erector Spinae muscle off of this? This is what you want to see. And oftentimes, to be honest, I can't see the needle almost ever when I'm doing a lumbar block, but my probe is locked. I'm not moving my probe from the skin. I know that's a transverse process. And then my goal actually is to touch bone. Like that's actually what I do, is I'll touch bone and then back off a fraction of a millimeter so I'm not inside the cortex, and then start injecting. Like you want to actually touch the bone for it and then back it up.
Hi, I just want to take a brief pause here to remind you of the courses.coreultrasound.com website, where we have full courses that are plug and play, that are built for residencies, medical schools, and fellowships. And we also have a bunch of other courses that we have put together over the past few years. We have a content creation course, critical care ultrasound course, a few sound and serves, Castle Fest on there. There's a bunch of courses that we have recorded that are, I think, really good content that are available to you on this website. Also, check out our question bank that has about 3,200 questions in it, and each question has a video explanation of basically why a certain question was a certain answer. Check it out, and now back to the video.
This is our last one. I don't think I'll be able to fit in sciatic, by the way. Sorry, we talked about it yesterday. I know that we tend to like this one here. These are all my pictures of patients that I have done fascial Yaka blocks for. Now, I will tell you that down here it works very well. Up here, it works okay. The reason why is the hip capsule is a very complex innervation, and a lot of the hip capsule is anesthetized by the obturator, and the back is all sacral nerves or the sciatic nerve. So you don't always get good innervation or good anesthetic of the hip capsule itself with an infrainguinal fascia iliaca block, which is probably it is the easiest one. But know that there are a couple of options. Basically, the higher up you go in the leg, the more of the hip you're gonna be able to anesthetize. How many of us have done the pain block here? Holy shit, that is very impressive, you guys. Great work. And how did it work? Was it easy? Was it hard? It's not that hard. You just have to have good technique and be comfortable with the needle going inside the body like that far. That was my little barrier, was that I'm like, 7 centimeters inside the patient's pelvis, right? But when you kind of get past that mental roadblock, it's actually pretty sweet, an easy thing to do. We're gonna focus just on this one. Here's our anatomy. We wanna go inferior to the inguinal ligament. That's gonna be our goal. We don't wanna go caudal. We don't want to go cephalad to the inguinal ligament. This is our target. And remember, we're not trying to get it right next to the femoral nerve. We're just trying to get it underneath the fascial plane and bathe the area. So hopefully some of the anesthetic, some of it will make it up and around this like little pinch right here from the pelvis and into this area. And you can imagine that it doesn't always work because of gravity. And one of the things to get around that is just use a larger volume. So if you have a patient, you can only do an infrainguinal. You can do 30 to 40 cc's of your local anesthetic, and you can dilute it too. You can use normal saline or whatever is recommended here to dilute it to get that volume. So the volume helps it kind of get over to hopefully get a little bit of the obturator nerve as well. Here is an anatomical picture of what we're looking at. Now, this right here, this triangle I kind of thought was the whole nerve, but the nerve itself is just this thing right here. This is actually like fat that surrounds the nerve. It's a small thing, it doesn't really matter, but just keep that in mind. I always think that's interesting when I realize that just this is the nerve, and this is fat. I always thought this whole thing was the nerve. And we're going all the way out here, and we're bathing that area. Here is an example of what that looks like. It's obviously sped up. We don't have great needle visualization, but we know that we're under there. We see that spread. Now, let's go through some quick cases. Case number 1, and I want you guys to tell me what block to use. Interscalene. I think interscalene would be great. What about this one? Which one? You could. The triple forearm block, it takes a little bit more work, and it is not reliably, it doesn't reliably anesthetize the entire kind of wrist area. So I've done that a few times, and I almost always have to like do something else when I do that. So for this, I almost always just do supraclavicular, just because it's so much easier. It's very dense, and I do one block and we're done. It's unfortunate, it's a bike wreck. Very unfortunate finding there. What about this one? What's the pathology? You guys got it. One of our attendings didn't get it and was confused why the patient had persistent pain and couldn't move their arm. This is called a light bulb sign, and it's a posterior dislocation. 30 points for you. Good job. Let's talk about our anatomy here. We're placing the transducer posteriorly. So everything up here is actually posterior, and everything down here is anterior, just so you know. Here is the humeral head moving within the capsule, and this right here is the glenoid, and then here's the rest of the scapula. Now, knowing that this is normal, we want to see the glenoid and the humeral head be essentially continuous. We can see what anterior dislocation, which is the most common on the left, and a posterior dislocation looks like. So this is how we identify those things. Make sense? Sweet, just like an extra little thing. This is what the CT scan showed. They're just stuck right there. It was interesting. What about this one? Remember, the forearm blocks don't work great. Like even if you do them at the proximal forearm, they really I would just assume that it just does the hand. And it really doesn't do the radial and the ulnar bones very well. It can numb them a bit, but I generally have to do something extra. But this is isolated, right? It's just one bone. There's not skin trauma. For this, I actually will do an ultrasound-guided hematoma block, which there are two things that I've done differently in the past 10 years than what I was taught. One of them is a hematoma block. The other one is a flexor tendon sheath block, which is an alternative to a ring block. The ring blocks worked about 75% of the time in my experience, and I thought I did them pretty good. I infiltrated a lot, but the flexor tendon sheath block, you just go at the callus, go down, hip bone, and then dump all of the anesthetic just under the flexor tendon, do a little massage, and numbs the finger. I've had 100% success for the past 10 years with that. The other thing is using ultrasound to do procedures that we are taught don't need ultrasound, like hematoma blocks. I've had probably 80-ish% with Landmark, which is palpating for hematoma blocks, but since I started using the ultrasound, I have 100% success with anesthetic because I can see my needle enter the area right where that fracture is. When you're injecting for these hematoma blocks, if you're underneath the tendon, you're in the joint, essentially. If you're just deep to the tendons, you're in the joint. I inject right there with direct ultrasound guidance. Cool? Any questions on that? All right, some final thoughts. If you're gonna do a block, this is what I'd recommend, is very good communication, because a neuro exam, this is a fascial Yaka block I did, the neuro exam is gonna be off, right? And that might scare our surgical colleagues. And so document it very well in the chart, and you can write it on the site so that it's on the patient so nobody gets confused. I think it's perfectly reasonable, especially if you're transferring a patient. Don't forget about LAST. And let's be very careful and think about compartment syndrome and know that there's been no instances of a ultrasound-guided nerve block blocking a sensory change with compartment syndrome. There's also been 0 cases reported of compartment syndrome using plain lidocaine. So if you're in a location that is high risk for compartment syndrome, use lidocaine because it'll wear off fast enough. That's what I do. And then we talked about this local anesthetic doesn't block ischemic pain, doesn't appear to. And then these patients are higher risk. And the reason why younger and male patients are higher risk is they tend to, on average, be a little more on the muscular side. And the more muscle tissue you have, the more likely you are to develop compartment syndrome because you have more muscle to swell, basically, and less space. If you think about like a high BMI non-ambulatory nursing home patient, they have it's no muscle, right? So they don't get compartment syndrome as much as a young, athletic person. Here's my contact information again. And does anybody have any questions?
Yeah, when you were talking about with the finger, where you just right below?
At the callus. So even if they don't have calluses, calluses usually are right here. And then I just basically go straight down, hit the bone, and then back off a fraction of a millimeter, just like it's almost like a hematoma block, and then I'll inject. I typically will redirect a little bit, so when I'm underneath the flexor tendon, I will kind of go this way a little bit, go that way just a little bit, but it's one poke, and it does a lot better. I use more than guidelines usually say. I don't use lidocaine with epi anymore. I used to, but then I heard a lecture from Jess Mason, and it terrified me that there is actually case reports of bad outcomes with lidocaine, ischemic outcomes with lidocaine. It's case report, so it's not common, but I don't use lidocaine. I usually use about 7 cc's on these blocks. So it's because I don't know why going from 3 cc's to 7 cc's would make that big of increased risk of complications. It doesn't make sense to me that it would be dramatically different. So I just use more. And especially if I'm using landmark guidance, like with the flexor tendon sheath block, I always overdo it. I always give more because I can't see exactly where the anesthetic is going. So I overcompensate by putting more volume. Like for the facial blocks, which I do frequently, I usually place about 5 to 7 cc's, whereas most places say 2 to 3. It increases my success rate. We had another question over here, I think? No? Any other questions? Great. Well, thank you so much, and enjoy your lunch or another lecture. Thank you.
I hope you enjoyed this second part of the lecture I gave at the Eisenhower residency. Now, we talked about a lot of things, and I don't necessarily anticipate that you're going to watch this lecture and immediately go be able to do a complicated nerve block, but it's a start. I'd highly recommend starting off with the forearm blocks or the posterior tibial blocks. Those are generally the ones that are a little bit easier and lower likelihood of causing any kind of harm if you've not really had a whole lot of experience doing them before. And make sure to reach out to your local champion and reach out to us. We're on Instagram, we're on Threads, we're on email. You can comment on one of our videos on Instagram, and we would be happy to help out where we can. I hope to hear from you soon, and happy scanning.